All right, recording.
All right, guys, welcome. We're going to go over a couple of review topics from our last lecture, a couple of review questions just to spark your memory. For those of you who weren't here for the last lecture, just do your best so we can go through and we'll just go over a couple things. So our first question, what structure is indicated by the arrow here on this MRI?
Kevin letting everybody know his answer.
Nice. Kevin's flexing on us. Confident, I love it. All right, so how'd they do, Jeremy?
76%. That's
damn it.
I said 76% pulled in.
Perfect. All right. So Jeff, you want to talk briefly about what we're looking at and kind of just talk here for a second?
Yeah. So again, kind of like what we were talking about last week, we're looking at a sagittal MRI of a knee joint. Again, just when you're trying to orient yourself, it helps to look at the bones. You see the femur coming down from the top, tibia coming up from the bottom, and the patella is on the left, which is the anterior portion of the leg. And just keep in mind that we know the patella tendon, or the patella, is attached to the patella tendon distally and quadriceps tendon proximally. So that's what we're seeing as the dark band projecting proximally off the superior bowl of the patella.
Beautiful. Perfect. All right, quadriceps tendon. Nice job, guys. Next question. What structure is indicated by this arrow here?
This is a good question into what you did last week.
Mm-hmm.
This was a tough one because I had to orient myself.
This is a little bit of a tough one, yeah.
Because I was like, all right, wait, what's lateral? What's medial?
Yeah, it's
So
definitely answerable, but it's a next level imaging anatomy question.
Yeah, I'd be very impressed if you guys get it.
All right. I need one more answer. Oh, there we go.
We should get it to a 50-50 shot. And so what we should see is, I'm hoping that our students get better than 50-50.
Yeah.
But
there we go.
all right.
Yeah.
All right, so
Right
Jeff, why don't you talk about this one for a second, because it's a little tricky, but I think it's a really good teaching point.
Yeah. So what we're looking
scared.
at here is a coronal image of a MRI of a knee. Again, you want to orient yourself. Superior is the femur, inferior is the tibia. And then again, keep in mind, you can judge medial lateral. Ideally, if you can scroll through the image, you'll be able to see the fibula, which will tell you what's lateral. But when you don't have that luxury, you also will be able to tell the difference between the condyle or the plateaus of the tibia. Tibial plateau medially is a concave surface, where it's convex laterally. As you can see on the right side of the image, there's much more concavity to the plateau, judging that, so that tells us the right side of the image is medial, left side of the image is lateral. Again, we're looking in the notch, so we know that it's likely going to be one of our cruciate ligaments. And then when you're judging whether it's the anterior or posterior cruciate, you just need to remember where they attach on the femur. The anterior cruciate ligament comes from the lateral femoral condyle down to the tibial spine, where the PCL attaches to the medial femoral condyle. You also can tell that there's a more of a vertical orientation of the ACL that you'll be able to see in this coronal and sagittal image that you won't really appreciate as much on the PCL. It has more of the looping trajectory from the very posterior aspect of the tibia up to the femur.
Cool.
Yeah. Also, to point out, the medial tibial plateau is usually distal to the lateral, as well as being concave.
Good point. Nice.
Yep.
All right. Sure. Tough shoulder. What structure is indicated by the arrow? I don't actually think I looked at this review question. Better get it right.
Joe, it's not the MJHL.
That's right.
Joe loves these questions. He's on sports right now. Loves sports.
Big sports guy.
Alrighty, there you go.
There you go. Good work.
Good job, guys.
So the majority of the group is correct. It's the subscapularis tendon. Again, without being able to truly orient yourself in the image, it's hard to tell which is anterior and which is posterior. When you're able to scroll through the slides themselves, you'll note that the coracoid process is going to be anterior, which if we scrolled more superiorly in this image, you can see it right where Jeremy's highlighting on the scan. Again, other things that you can use to help identify anterior posterior, you can see the bicipital groove with the lesser and greater tuberosities. And then we also know that the subscapularis attaches to the lesser tuberosity, the anterior aspect of the humerus. Additionally, once you guys start to get a little more comfortable with these images too, you'll be able to answer questions based on what you know is really visible on certain images. An axial image is not going to show your supraspinatus tendon very well because it runs in the same plane of the image itself. And then the teres minor and infraspinatus are part of your posterior cuff. So if you can identify anterior and posterior, that will help you narrow down the answers in these types of questions.
Nice. Question 4, what structure is indicated by the arrow?
We're at 100% right now. Let's keep it going.
Love that. Love that.
Ah, just lost it.
God dang.
Who was that?
God damn it, Backo.
Sabotaging?
Probably
How'd
Galloway.
they do? How'd they do? I'm going to show it, Jeremy.
All right. Awesome.
Woo! I got it right.
Great.
Thanks.
So again, similar to the last question, I'm glad to see you guys picked up on it. We're in the same orientation, so we know that we're looking at a posterior versus an anterior structure. Again, the biceps tendon is found laterally in the bicipital groove. And again, we know it's posterior and looks like it's an intra-articular structure, so it'll be part of the labrum.
Hey, Jeff, what type of athletes usually injure their posterior labrum?
So you got to think about the people who are going to be putting their arms in certain positions that will put a lot of stress directly posterior on the labrum. Typically, you think of people that are either like offensive or mainly offensive linemen in football who have their arms up, essentially a repetitive posterior loading of the shoulder. Also, people who are lifting heavy weights, particularly bench press, puts a lot of pressure on the posterior labrum as well.
All right. A fun question. Here's the GOAT. Anybody who's been watching The Last Dance, I just finished all of it. Pretty good.
Oh my gosh. This should be 100%.
I don't think it's going to be 100%. Yeah, see?
I'm already disappointed over here.
Yep. It's a very serious question, Brian. Brian Batko, Chicago, Illinois.
All these people
AI.
too young.
You know we're going to get some. Wow, only 59%. That's wild.
That
Holy
is
cow.
wild, dude.
That just means we're old, I guess. If we think MJ's the best, and then it's a younger generation thinks it's Kobe and LeBron, and I don't know.
Hands down, Jordan.
That would be my bet, but all right. Okay, guys.
Brian Scalabrine out on the list.
Ooh, Scal. Who said that?
Ari
whose
Berg.
That was
recommendation
Ari
that?
Berg, sir.
Ari.
Hey, Berg.
Got a New Jersey represent.
Attaboy. All right, guys. So let's get into this lecture. This is going to be a dense one. Bear with me. hopefully you guys have a beverage of choice with you, most likely something to help keep you engaged in this lecture. I'd like to thank Dr. Benevenia and Zach, our tumor fellow, for their slides and for their education. This is going to be a lot of things. We're going to try to give you a very broad overview and try to give you the tools to apply to bone tumors and in our approach radiographically. So we're not going to really get into having you memorize charts or memorize what things go in tables. But if you can break things down into a few categories, this will give you a good starting point when you have a rotation in oncology. So before we really get into our imaging, talk about kind of our diagnostic strategy. And so we combine both clinical and laboratory information in addition to our imaging. And this is going to help us kind of help formulate our differential diagnosis. So this imaging is extremely important. Every patient, when you're worried about an oncologic diagnosis, should get a plain X-ray, which is incredibly valuable in starting the diagnosis. But don't overlook the importance of a careful physical exam and a thorough history taken. So again, as we said, basic evaluation, you start with your history and physical, start with a plain X-ray. Once you go from there, you've got a lot of information that you can form a preliminary diagnosis, and then you can go from there in determining what advanced imaging or laboratory testing you might need in the workup. So just some things to keep in mind before we get into imaging too deeply. The physical exam, does the patient have a mass? Do they have swelling and warmth that may, consist of something other than an oncologic diagnosis like infection? Do they potentially have a DVT? Do they have skin abnormalities that could point you in the direction of a specific oncologic diagnosis? What deformities do they have, and other areas that you can just be on the lookout for? Being thorough and examining the patient fully, including their skin, is really important in this patient population. So we're going to talk mostly today about everything else, about imaging, but don't forget the importance of a careful physical examination. So we're going to break things down into 4 categories today. We're going to talk about age, location, morphology, and then size and number with regards to oncologic diagnosis. And if you can break things down into those categories, you're well on your way. So, like we said, age, morphology, location, size, and number. Gender plays a small role, and we'll talk about that. So, what are the 2 most important factors? Like we said, age, location. Going to keep banging it into like mud on the chicken wire for you guys to keep remembering. So we're going to break things down into 3 major categories today. This is for kind of the ease of conceptually understanding stuff. Younger than 20, talking about adolescents and younger children, young adults to middle-aged 20 to 40, and then older than 40, and then factoring this into our diagnoses. This is for your reference, which will be sent out with a PDF, but it's a nice category of just some of the pathologies listed on Ortho Bullets. I thought this is a great slide just for you guys to refer to later. Similarly, this is something for you guys to refer to, but it talks about the peak age of bone lesions and looking at each category to just start to familiarize yourself with the general groups of diagnoses by age. Let's talk about location. We're going to spend a little bit more time on this. So we talk about the type of bone, right? So an axial skeleton, highlighted in yellow, versus your appendicular skeleton. Appendicular skeleton includes your upper and lower extremities, portions of your shoulder and pelvic girdle, and clavicle. And so, we'll start to break down a little bit today what lesions occur where and how that kind of factors into your diagnosis. So, which bone? So we talk about, in terms of commonality, different lesions occur in different portions of the bone at different rates, right? But some of the general tenets of this are that areas of higher metabolic turnover are frequently found with a more commonly occurring bone tumor. So, if you can think about it this way, one of the most common places for bone tumors is the distal femur or at the knee, either distal femur or proximal tibia. When we think back to our skeletal growth, these are 2 of the areas of the most rapid rate of growth. And so that's one of the ways I can always remember as very common locations. Also thinking about the proximal humerus, where as high as 70 to 80% of the length of the humerus comes from the proximal humerus. That is another very common location for bone tumors. And we're not going to get too much into the nitty-gritty of which occurs where but I will have some charts for you guys to refer to on your own time, which I think will be helpful. The other thing we talk about is the location of the bone tumor. So within the bone, is it in the epiphysis, past the physis? Is it at the metaphysis, or is it at the diaphysis, at the shaft? And so different lesions and different types of pathologies frequently occur in different areas and are often respectful of those zones and respectful of the physis, but we're going to get into a couple diagnoses that do not respect the physis. Again, this is just our diagnosis, our list here. A lot of this is for your reference, but I want you guys to have it. Talking about epiphyseal lesions, 3 of the most common ones I thought were important to mention were giant cell tumor, chondroblastoma, osteomyelitis. Now, giant cell tumor and osteomyelitis are a little bit unique in that oftentimes they will expand across the physis. And so that's something that you see in these types of lesions. Metaphyseal lesions, there is an enormous list. We're not going to memorize it all today, but think about, one of your most common zones. You think about osteosarcoma, one of the most common bone lesions that there are, especially in children. And so that's an important one to keep in mind that people will ask you, I'm sure, on your rotation. This is, again, for your review, but again, highlights that conventional osteosarcoma as well as chondrosarcoma of the limb most commonly occurs in the metaphysis. So those are 2 big ones that you guys, I'm sure, will be asked about and want to be able to detect. Looking at diaphyseal lesions, again, there's a variety of lesions that occur at the diaphysis. One of the big ones we talk about is Ewing sarcoma. So just to keep that in mind, and you'll have this list for your reference. All right, so let's talk about the typical location. This was always something that challenged me early on to understand. So I think central is pretty straightforward, meaning that it's a centrally located lesion. When we talk about an eccentric lesion, it's a lesion that is within the bone, within the cortices, but on one edge of the medullary canal. It's occupying an eccentric region of it. This is different from something like a cortical lesion, which is a cortically based lesion outside of the cortical edges of the bone. And then we talk about a parasteal lesion, which is, we talk about typically having a stuck-on appearance, meaning that it's laying on top of the cortex. And then we talk about intra-articular pathologies. And so if you can start to look at a lesion and break them down into these categories, you've gone a far way to helping form your differential. Again, another reference slide for you guys to look at. This just has some of the locations within bone for you to refer to, some of the centrally located lesions and some of the more cortically based and eccentric lesions. This is a great reference slide for you guys to refer back to. This is just some of our differentials by the location in bone, again, for your reference. But I thought this was a really helpful slide for you guys, and it'll be sent out on the PDF. So let's combine age and location, because you may have a similar presentation radiographically, but age becomes a big factor. So here's a slide to kind of just demonstrate the differences, similar locations, but based on their age. So we look at things that kind of stand out, things like in a young patient, osteosarcoma, an osteochondroma, ABCs, NOFs, Ewing sarcoma, chondroblastoma, lesions of youth, right? So you talk about age over 30, you're looking at giant cell tumor, enchondromas, chondrosarcomas, and the list goes on. One of the things I want to point out from this slide and over again, infection is always in your differential. And so no matter what the patient's age is, don't rule it out. Always keep it in the back of your mind, because it behaves in many different ways and occurs in any age group. So it's important to not rule that out. Again, some more reference slides for you guys to take a look at on your own time. Some of Zach's really cool animation here. I like it. Oh, he must have had something really cool to say. I unfortunately don't. All right, going back to our framework here. So we talked about age, talked about location. Let's talk about morphology. And I hope Joe Galloway stops me at some point, because he's a very, very good explainer of this. I know he always highlights the importance of what is the tumor doing to bone and what is the bone doing to the tumor. And these are two different things, even though they can sometimes appear in similar ways. It's important to understand the concepts of what that means. So let's get into it. So we're going to talk about a couple things into how to better identify the morphology of the lesion. We're going to talk about the margin of transition. That's where the tumor ends and the bone begins, and vice versa. We're going to talk about the amount of bony destruction. So these are two things that the tumor is doing to the bone. Then we're going to talk about things that the bone is doing to the tumor, such as the periosteal reaction. We'll talk about recognizing soft tissue extension, and then we'll talk about matrix-producing tumors and the difference between a bone-producing tumor, a cartilage-producing tumor, or a tumor that doesn't produce any matrix, and kind of how that correlates with its radiographic appearance. Scary or not scary, right? So, you know, we're gonna get an idea of what is an aggressive appearing lesion, something that is pointing you in the direction of a malignant tumor potentially, or an aggressive tumor. Those two are not one and the same, and we'll get into that as well.
So Joe, can you go back to that slide?
Yeah, for sure.
So these markers located on the left side of the slide, those are all your cheat code. Those are all the things that if you can identify a characteristic for each one of those bullet points, it will tell you, is this a scary lesion or a not scary lesion?
Very true. One of the things, and this was one of Zach's slides, which is a really important thing to point out, is the overlap of some of the morphologic features, right? So you may have something that has a, these things are not black and white. You may have something with a blurred zone of transition. We're going to talk about what that looks like, a wide zone of transition that also has associated bone destruction, right? You may also have a bone tumor that has a lot of periosteal reaction, and because it's so aggressive, it also has soft tissue extension. So these things are not necessarily in a vacuum, but it's kind of on a spectrum, and we'll talk a little bit more, but I just want you to kind of keep that as your framework as we move forward. So, big picture, the zone of transition, how wide or how narrow it is often tells us the biologic activity and the growth rate of the tumor. So if you have something where there's perhaps a more narrow, well-defined margin of transition, this is something that has less biologic activity, a lower growth rate, a less aggressive appearance. If you have something where the margin of transition is stretched out and it's wide, the bone has not had time to wall off this lesion. So we talk about kind of, again, that combines what the lesion is doing to the bone and what the bone is doing to the lesion. But I want you to just keep this in mind as you have a wider transition, this is a more aggressive lesion. We'll show some pictures that help kind of better understand this. The other thing we talk about is the geographic nature of the region. So we talked about zones of transition. We'll have some pictures later. I think I switched the slides here. But looking at a lesion, is a lesion geographic or non-geographic? Meaning, does it look like you can find it in a well-defined region, or does it look like the tumor is spread out all through bone? So if you look at the upper picture, this is more of a geographic lesion, where you can see kind of this circular area. There isn't a tremendous amount of sclerosis, which we usually describe as a white rim surrounding the bone, but the area of, the lesion, you can describe it in a certain area. When you look at the lower right here, when you have, we might describe as more of a permeative pattern, it's kind of scattered. It's not very well defined. So this is just an example of you to keep in your mind. And again, the bottom right would be a more aggressive type lesion than the left one. Hi, Carolyn. Zone of transition. So again, this is your most reliable indicator. Like we said, narrow lesion, this is well-defined, wide, usually imperceptible and can't really be drawn. Two examples I got from Dr. Benevenia. So we talk about a benign lesion here on the left. You can, this isn't the most well-demarcated lesion that I've seen before, but I think that that's the point, that you're not going to see things purely in black and white on your rotation, but you can see that the lesion is stopping at a pretty definitive region here. When you look at this tumor here on the right, It's pretty wide, poorly demarcated. It's hard to see where the lesion ends and normal bone starts. And again, that's something that shows that this is likely a faster growing, more aggressive tumor. If any guys have any thoughts, let me know. But here's some other examples here, looking at the zones of transition. Narrow here on the left. So looking at this lesion, you can see this white area, right? We would call this a sclerotic border surrounding the bone lesion. And what that means is that the bone has had time to wall off this tumor. It's been likely a slower growing tumor in nature, and the bone is laying down bone, walling it off. When you look at something, let's say on the right here where my cursor is, it's really hard to say, where exactly this lesion ends. And again, that's what we're kind of talking about, the wide zone of transition. Kind of reinforcing our point, we can assign, numbers and types to these. Sharp and sclerotic, like we talked about, very walled off with that white edge. We talk about sharp and lytic, meaning that there's a little bit more aggressive where it's still geographic in nature, but the zone of transition isn't tremendously wide. So this is sharp and lytic. And then ill-defined, you see a lesion here with associated loss of normal bone structure. And that's kind of your more aggressive type pattern.
Hey, Joe.
Yeah.
Can a lesion be both geographic and have a wide zone of transition, or
Yes.
vice versa? Can it be permeative or not permeative? Can it be moth-eaten with a narrower zone of transition?
It can be moth-eaten with a narrow zone of transition. It gets a little bit tricky. I didn't want to delve too deep of, these things are kind of on a spectrum.
Yeah.
Tell me your thoughts, because you're kind of coming at it from an angle. I'd love to hear what you're thinking about it.
Well, no, the only reason I asked was because when I was first reading about this stuff as an intern in a second year, that confused the heck out of me. And my current understanding is that a permeative lesion is so aggressive that it always has a wide zone of transition. Those two just—
That's correct. Permeative cannot be geographic.
But then
wide.
You can have geographic lesions, which you can sort of see how you can define the borders of the lesion, but the lesion might not have a very localized sharp transition. It may sort of fade out, but you can still localize each one, where each area, and it's sort of centralized. Whereas you can also have a moth-eaten thing that has very defined zones of transition, but it's not localized into this one sort of central geographic area. So yep. I think that each one is a spectrum that gives you clues to the aggressiveness of the lesion. But once you, like you said, once you get to a permeative lesion, is by definition, it's a wide zone of transition.
Yeah, I think that's a good way to describe it. To use one of my New Jersey terms, I guess, that what you're describing, that situation is kind of a tweener, in between the, the type 1B and the type 1C that we're talking about. And so a moth-eaten appearance, that in itself is sometimes associated with different types of lesions. So being able to recognize that is important. But recognizing the aggressiveness, I think, would rely more upon the zone of transition. But that's not to say that these are all just pieces of the puzzle that you're trying to put together. So being able to recognize each of those individually is important. But having a general sense of its aggressiveness, I think, is kind of the overarching theme, at least for today. So here's an example of a geographic type lesion. This is typically, a benign, slow-growing, narrow zone of transition, very well circumscribed. Type 1B is where we talked about the sharp lytic. So you can see that it's well defined, but you don't see a tremendous amount of sclerosis here. And this is a little bit more aggressive, right? Intermediate is what we're calling.
So this is a perfect example of where here, this is geographic, it's localized to one spot.
Yes.
But the zone of transition is a little bit less clear than the example just before.
Correct.
Yeah, so
this is
Jasmine just on that point, Jasmine asks, can a lesion have a wide zone of transition and clearly demarcated borders?
So no, because the zone of transition really is dependent on the border thickness, right? And so what we're talking about here, so the difference here, when you look at this lesion, you have a narrow zone of transition, number one, because normal bone is right here. Abnormal bone is right here. It is a very narrow space. In addition, though, there is a increasingly, we might say even hyperintense type appearance, a sclerotic appearance surrounding this area that the normal bone is walling off the lesion. This is what we talked about it being slow growing. So that's the narrow zone of transition. Here, now, like Joe was saying, this is geographic in nature in that you can define it. But if you look, these edges here, hopefully my mouse can come up. There is some, what I'd call, for lack of a better term, we can call it blurriness, right? In between these zones. So it is more poorly defined. It doesn't necessarily mean the lesion is tremendously less geographic in shape, but the demarcation is sharper on this slide than on this lesion. I hope that makes sense.
Just to jump in for a second, just add a great question.
Zach's here.
But I just think the overarching theme is just don't get hung up on too much of these specifics of, is it geographic, is it moth-eaten? Just kind of look at the big picture. Like, is there a clear border? Can you clearly tell, like, this thing has been there for a while? Has the bone reacted to it? Which I know Joe's going to get into this more. And Joe, I'm guessing your next slide is the 1C lesion. So if you go to that, you'll see, I'll let you get into it, but you can see where you have certain areas where it's more geographic and kind of punched out area where you can, it's clearly well circumscribed, but that's embedded within an area where it's a lot more permeative. It's not well defined. So they're all still, it's a spectrum, and that certain features don't necessarily, the overall features are what defines the aggressiveness of the lesion, and don't get hung up on too much on the terminology. It's good to be able to describe it, but I think all of us are looking at that and say that's concerning, even though you have a couple areas of pinpoint, where it's a little more geographic and well demarcated. Again, you don't have a distinct margin, a distinct zone of transition. So I just want to jump in there for that.
I think it's helpful to remember that these are all just terms that we've applied to images that we're looking for, and we're doing our best to describe them. The tumor doesn't respect the words that we use to describe it.
No respect. I like it. Okay, so we talked about 1C and ill-defined. I think this is probably the easiest one to understand. This is aggressive appearing, right? We're talking about extra bone formation. We're talking about a permeative pattern, talking about maybe a Codman's triangle there. So this is the kind of thing when you see should make you concerned, right? When you see this, you should still investigate it, but something like this, even at your level of training, should make you raise your eyebrows and say, okay, this is a problem. And then we can go from there on the workup. But getting in the habit of recognizing these is going to be important no matter what your specialty is, because people will present to you with this. So bony destruction, just kind of firming up some of what we talked about. We talked about a geographic pattern. We talked about a moth-eaten appearance. This is when, what kind of Joe was getting at a little bit, and then a more of a permeative pattern. And we can go through lots of charts that look at the different types of presentations, but just being able to recognize these distinct categories gets you pretty far. All right, this is Zach's here. So skipping type 1, same as margins, which was geographic, looking at a moth-eaten pattern. So Zach, you want to talk about this slide? Because I really like this one, but I missed when you kind of gave your spiel on the moth-eaten section.
This sec, let me get out of tumor conference so I don't hose the next PGY4 tomorrow. Jeremy, that's for you. So when you see, this moth-eaten is kind of defined as, so you see these areas, the diagram is kind of, gives you a classic picture, but you see this it's almost like a showered areas where there's certain cells that are forming a lytic area within the bone at different discrete periods in time. So you're going to see some areas where it's more punched out. There's a lot more lysis within the bone. It's a lot darker. So if you were to kind of isolate, so the area where there's kind of I guess it's a clear area, I guess I would say, that area is a little more well defined. But then when you look at, more to the top left of the x-ray, you see these areas where they're at variable stages of kind of the erosive process within the bone. And that's kind of your classic moth-eaten appearance, is you're seeing multiple different areas of bone destruction, but they're occurring at slightly different time points. It's not a single isolated lesion. So it's usually scattered across a larger area within the bone. It's usually, again, associated with an aggressive pattern, and it's not just one single discrete lesion. So it's something common you see with like a metastatic disease, where it's kind of, you have, showering of metabolic or embolic type metabolic or metastatic cells that are, again, kind of entering into the bone at different time points that are having this focal bone destruction, but it's not all consistent at the same time. So that's why you see this kind of patchy type appearance.
Nice. We talk about type 3, which I think we've kind of beaten the horse dead a little bit, the permeative pattern, but I think this is a nice example of just kind of a wide area of bone destruction without a well circumscribed pattern.
And honestly, telling the difference between moth-eaten and permeative, I mean, there's a difference when you see it. But again, the take-home point is it's aggressive. It's concerning. Don't get too hung up on the terms.
Like you said, big picture, right? So yeah, this is exactly what you're saying, Zach. So, looking at a permeative pattern, very aggressive on the left. This moth-eaten is also an aggressive appearance. So, the aggression of the tumor should be kind of your starting point. And that's where you kind of lead off for morphology. Again, like you're saying, kind of Zach and Joe have already touched on this. Don't get caught up in your terminology. Both are telling you that the lesion is fast, growing, and it's aggressive. And so this is something that needs to be investigated further, worked up, and potentially treated. Periosteal reaction, again, how is the bone responding to the tumor? So is it solid uninterrupted? Is it interrupted? And so when we talked about this, we kind of already touched on this, but the bone is laying down, the native bone is trying to wall off this lesion in this solid and uninterrupted pattern. And because the lesion is not overly fast growing or maybe not overly aggressive, the bone has time to wall it off, giving you that area of sclerosis and giving you that kind of solid and uninterrupted area of bone formation. If you have a tumor that is overly aggressive, right, it is growing faster than the bone, the native bone can lay down bone to wall off this lesion. We're going to show you some pictures, I think, that are helpful here. Again, this is for your review, looking at kind of the different areas of periosteal reaction, which are nice. So this is what we talk about, right? So we talk about a solid, uninterrupted area. So you can see these arrows kind of with a abnormal appearance of the cortical edge of the bone, but it is solid and uninterrupted. And this shows that this is likely a slow-growing benign lesion. Let's compare that with something like this, where you can see, several layers of bone being lain upon. And we talk about onion skinning, right? We talk about this in Ewing sarcoma, something that should be kind of popping off in your mind. Taking it a little bit further, talk about hair on end or a stun burst pattern. Oftentimes we talk about this in osteosarcoma. You can see all of this bone formation almost shooting off the bone. And so, naturally, I think by looking at this, you can tell that this is something that's more aggressive, right? And so then we talk about Codman's triangle as well, right here, this edge here of increased bone formation. You can see on this picture on the right of the proximal humerus, a permeative pattern with Codman's triangle. This is a very aggressive lesion. And so, that's kind of the take home, more than predicting exactly what diagnosis it is, getting in the ballpark of knowing, is this aggressive, is this benign? That's where we want you guys to start. And this is, I just like this slide, this nice spectrum of disease here that Zach had from his talk. So Joe Galloway's favorite questions. Ask yourself 2 questions. What is the tumor doing to the bone? What is the bone doing to the tumor, right? Do you have an ill-defined margin of aggressive bone growth and aggressive bone loss has a wide zone of transition? And then, these things are related. So if you have that tumor that has a wide zone of transition, that is aggressive, that is eroding bone rapidly, it is moving faster than the native bone can lay down bone around it to wall it off, meaning that the margin will not be well defined, meaning that you will also often have periosteal reaction because the bone is trying to act almost more aggressively to wall off this tumor, right? And so these things go hand in hand. So a more aggressive appearance when we talk about a permeative pattern, wide zone of transition, large amounts of periosteal reaction that's poorly defined in its margin. I think that's what I want you to remember for an aggressive appearance. Joe, anything?
Oh no, I think you hit it all. These are the reason I enjoy these is because it's this Dr. Eineking, who is one of the guys who pioneered a lot of what we know about all this, said that there were 4 basic questions that the general orthopedist should be able to ask himself about bony tumors. He said, what bone is the tumor in? What's the tumor doing to the bone? What's the bone doing to the tumor? And are there any clues within the tumor or radiographically that can tell us about the substance of the tumor, meaning like the matrix? Does it look cloudy? Does it look like popcorn? Does it look like stucco? Stuff like that. And that's just sort of always stuck in my head. The age of the patient is probably the #1 most important diagnostic clue. But then within that, anybody should be able to nail these 4 questions. And if you just go over them over and over again, every tumor you see, every lesion you see, what bone, what's the tumor doing to the bone, what's the bone doing to the tumor, and are there any clues radiographically within the tumor? What's it look like in there? And if you do that over and over again, you will narrow it down surprisingly fast.
Joe, did you say matrix?
Matrix, yeah, that's the clues within the tumor. What is the matrix
What do
like?
you know?
Hey, before you go on, just a couple of questions from the chat.
Sure.
Does the amount of reactivity or bone formation around the malignancy directly correlate with malignancy of the tumor, or is that not necessarily true?
Let me read that. Does the amount of reactivity or bone formation around the malignancy?
Yeah, so I think, to try and distill that down, what Joe was saying earlier is the amount of reactivity of the bone formation around really falls under that question of what's the bone doing to the tumor. So how is the bone reacting to the tumor's presence there? And if you have a tumor that's growing very, very fast, just think of it like the bone doesn't have enough chance to catch up. The bone's trying its darn hardest to wall that thing off, but the tumor is growing faster than the bone can lay down a wall. And so the pattern of bony formation that you're going to see is going to reflect that. So that you won't see a lot of bony reactivity because think of it like a war, and the tumor is winning and it's advancing the line of attack farther and farther, and the bone is trying to change its location of attack. And so it never has a chance to really lay down enough substance that you're going to see it on an x-ray. Whereas something that's growing slowly and has a very slow advanced line of attack, the tumor can just lay down this big wall. The bone can lay down a big wall, and the thicker that wall gets, the better it contains the tumor, and it keeps on laying down more because bone is really dumb, and the only thing it knows how to do when stress is applied to it is make more bone. That applies to fractures, tumors, walking, not walking, space, water, everything.
Just to add, Joe, that was perfect. Just to add one other clarification, I want you guys to remember that there is a difference between aggressiveness of the tumor and malignancy. Malignancy is an oncologic term. So to your question, saying, does the reactivity of bone formation around the malignancy correlate with malignancy? I would say that it oftentimes, maybe not always, but often correlates with aggressiveness, right? But there are bone lesions which are locally very aggressive, but not malignant, right? And there are lesions that are malignant, but not necessarily as aggressive as benign lesions. So when we talk about benign and malignant, we're talking about an oncologic term. When we're talking about aggressive and non-aggressive, we're talking about a radiographic, more of an ortho term, if you will, when we're looking at these radiographs. And then Hassan asked about permeative, the amount of bone involvement versus a moth-eaten appearance. I would say that permeative pattern may have slightly more bony involvement. It's certainly further on the spectrum of aggressiveness. So that's, that's not perfectly answering your question, but, the permeative pattern is certainly the more aggressive than a moth-eaten. Yes. Okay, I thought Joe was answering it seriously. There you go. Very good, Joe. All right, so let's talk about matrix. So matrix represents the intracellular material produced by the tumor cells. We talked about we can produce bony, cartilage, fibrous, or no matrix at all, right? And so this is Joe's fourth tenet of what are those characteristics of the lesion that help you, give you a little bit more if you could. So talking about an osteoid matrix, right? This is where you have, you'll have these patterns with kind of a solid cloud-like and ivory-like opacity. That's how you can kind of tell that it's a bony or an osteoid matrix. Just for your reference, we talk about some of these lesions that are bone-forming tumors. Once you get in the habit of recognizing these patterns, then you can get in the habit of memorizing, but I want you guys to know the core concepts before you worry about memorizing tables, but it's here for your review. Chondroid matrix, right? We talk about, there are a couple different patterns of chondral mineralization. We talk about, stippled, flocculent arcs and rings, and we have a slide on the next one showing this. But you can see, looking here with this cartilage formed inside of the tumor, you can certainly see, the difference from this very ivory-like substance. So hopefully that's something you guys can start to pick up a pattern, but I personally feel this is the most difficult of the four to be able to conceptualize. So again, cartilage-forming tumors for your review. And this was a great slide here showing kind of the difference between stippled versus, and flocculent, and then the rings and arcs. Zach, do you want to talk about rings and arcs? Because I always seem to twist
I think it's a crack of
when I
shit.
start talking about it.
And that's what I was taught actually as two of my attendings when I was a resident, both trained at Gainesville, the home of Enneking, and both of them will tell you, they're sitting there, they're like, I don't know what the hell the rings and arcs are. You can see this stippled appearance. The best explanation between the difference between chondroid and osseous matrix that I heard was, if you think about, you have a can of paint on a wall and then a wall. If you dip your fingers into the paint can and you flick it on the wall and you have the kind of speckles around, that's more what a chondroid matrix would look like. If you
Gotcha.
stick your thumb in the paint can and then wipe it on the wall, it's more smooth, more consistent. That's more, what you'll see with an osseous type of matrix.
It's pretty good.
I think
makes sense.
kind of conceptualizing it makes the most sense. And honestly, arcs and rings, if you can have a great example and you can draw it out for me, by all means. I think it sounds great on paper, but I know many smarter orthopedic oncologists than me who call bullshit. So I will second their bullshit.
That's good for the students to hear, though, because I remember being a student and trying to understand it, and it's like, is it me? Am I not getting it? So again, having the big picture in mind, I think the paint can, I really like that. I don't think I heard you say that the last time. So that's a good way to think about bony versus chondroid matrices. And then no matrix, right? And so this is the challenge here with no matrix. It can be a wide variety of lesions, right? You can have a simple bone cyst, like you see on the left here with this skeletally immature patient, or you can just have rapid bony lysis, right, from something like metastatic disease. So again, you may have down your radiographic appearance, you may have, a sense of how aggressive it is, you may have all these other senses, but this kind of highlights the importance also of age and physical exam in these patients. So you got to bring it all together, all the pieces of the puzzle. Soft tissue extension, we're not going to spend too much time, and we're not talking about soft tissue sarcoma in this lecture. It would just be too long, but you talk about, cortical destruction can be a sign of an aggressive lesion. And it'll either be contained within, your bone and your new periosteum, or it's going to break out. And then when it breaks out, it often abuts or invades the nearby soft tissues. And so you can see here, this is not normal appearing. Certainly you can see bone loss, but you can see kind of this poorly differentiated margin between the edge of the bone and where the soft tissue begins. And so that's just what we're talking about on soft tissue extension. And you can often appreciate that on a radiograph. Don't overlook the x-ray. That's one of the big points today. Every one of these patients, they may have an MRI, they may have a CT, or coming in with advanced imaging from your medical practitioner. Do not overlook the importance of a radiograph in these patients. Okay, so we talked about kind of all these things. Margin of transition, or zone of transition, bony destruction, what is the bone doing to the tumor, and then what's the soft tissue extension. And this is all telling you about the aggressiveness of the lesion. So like we kind of already touched upon, aggressive and malignant are not the same thing. Malignant is an oncologic term, and aggression, aggressiveness of the lesion is a radiographic term. Size and number, going to go through this pretty quick. Zach, I like this, but I think this gets a little complex. But this is for your review. Certain lesions have size criteria. So when you talk about an osteoid osteoma, usually you're talking about a nidus that has to be under a certain amount, right? And then when you're talking about an osteoblastoma, you're talking about the nidus has to be over a certain amount. So it's just, there are some numbers in here to keep in mind. I'm going to kind of leave this one for your review. Okay, so we talked about all these other factors. Age is very important. So this is one of everyone's favorite PIM questions. What is your differential in a patient over 40 with multiple lesions? Mets, myeloma, lymphoma, right? So in older patients with lytic bone lesions and with multiple lesions, you're talking about those three categories. They should always be in your mind. And infection maybe, but a lot of this is great, but it's for your review. I'm going to leave this for you guys to look back on, just so I don't have to pronounce the first diagnosis.
Osteopoikilosis.
Thank you. I was going to sound like an idiot if I tried to do it.
So you learn your fellowship.
Yeah, there's time. Okay, broad strokes. Let's bring it all together, right? What's scary? Poorly defined, wide zone of transition, interrupted periosteal reaction, cortical disruption, and soft tissue extension. I know we're saying it over and over again, but again, these basic things, if you can understand these concepts, you are so much further, honestly, than I was when I was starting the tumor rotation. So this is really good to have. Things that are not scary, right? Things that are well-defined, things that have a narrow zone of transition with a solid continuous periosteal reaction or rim of sclerosis, and with bone forming around the tumor, kind of containing it without it breaking out of the cortex, right? These are showing you it's a less aggressive lesion. So take home points: location, 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 right? Don't forget age, morphology. Is it scary or not scary? And don't forget your physical exam. Don't forget your history. It is really important. And don't overlook the x-ray. We're going to do some questions, just see how you guys, hopefully you guys kind of gathered it all together. Do we have any questions in the chat before we did the questions, guys?
Nothing right now.
Cool. All right, so let's put up the poll. 14-year-old male, right foot swelling. How would you describe the radiographic appearance?
Yeah, perfection.
Nice, cool. Now this stuff, once you start breaking it down, it's not quite as complicated, you know. Nice, narrow zone of transition. All right, 15-year-old female with arm swelling. How would you describe the radiographic appearance? How'd they do, Jeremy?
Pretty good.
Pretty good. So again, this is a lesion in the humerus. We talk about a poorly defined region of bony destruction, calling this permeative. And then we look at the periosteal reaction right here. And you can see the multiple layers and level of aggressiveness here. That's an aggressive periosteal reaction. This is an aggressive tumor, or Zach would say, scary. Question 3. You have a 63-year-old female who has weight loss and pain when ambulating at her left hip. What is the most likely differential diagnosis? So over 40, kind of scattered lesions throughout the proximal femur. Love it. So, Mets myeloma lymphoma, that should be in your differential. Other things to just point out, we talked about osteosarcoma, Ewing sarcoma, and aneurysmal bone cysts are typically etiologies of younger patients, though not necessarily, but for the purposes of simplicity in this lecture. And then fibrosarcoma and UPS, those are soft tissue sarcomas, just to keep in mind. So tried to throw in a little curveball. Lecture question 4. So you have an 11-year-old male with hip pain and on the playground. What is your most likely differential diagnosis? So thinking, is this, aggressive or not so aggressive in appearance? Is there any matrix being produced or not? And then taking a look at, the amount of bony destruction and bone formation.
You're gonna have to do some explaining, Joe.
How'd we do? Yeah, I figured that's why I put it last. This one was going to be a little bit trickier. So let's start with question C. So this is an 11-year-old male, and some of this requires not background knowledge that we didn't really talk about in this lecture, and we're going to probably talk about in future lectures. But we talk about giant cell tumor typically occurs in patients somewhere in between, let's say, 30 to 50, right? So this is an 11-year-old male. It's unlikely that they would have giant cell tumor. It is a lytic lesion. That's, so it fits that criteria, but age is kind of your hallmark there. Similarly to chondrosarcoma, again, it's fairly uncommon for an 11-year-old male to have chondrosarcoma. It's a disease of, closer to middle age when we talk about it. And then, things like osteosarcoma and Ewing sarcoma, age isn't necessarily your cutoff here. Osteosarcoma certainly occurs commonly in this age range. Keep in mind that osteosarcoma has a bimodal distribution. So it'll also occur in patients, older patients, oftentimes secondary to radiation therapy. That's for another lecture, another day. But looking at this X-ray, you can see that this is a less aggressive appearing lesion. So for that reason, it's certainly not an osteosarcoma. You don't see a sunburst pattern, cortical destruction, and this looks like a fairly geographic lesion here. And so that would be, and similarly for Ewing's, which is also an aggressive type lesion. Location plays a role, right? Remember, we talked about osteosarcoma and the metaphysis, Ewing sarcoma and the diaphysis. But again, based on the lack of aggressiveness in the appearance of this lesion, it would not fit into those two diagnoses. And then this is more likely a UBC, but I wanted to just give you guys another one. Hopefully that makes a little sense. Zach, feel free to jump in if you want to add anything here.
I admittedly missed a lot of that, but I think the key part is, we talk about all the other tumors that are on that list aside from, and you can, argue ABC also has aggressive features, but definitively your sarcomas, giant cell tumors, and low-grade, even a low-grade chondrosarcoma, those all have aggressive features. And just taking one look at that X-ray, you see that the cortices, they're thin mildly, but they're relatively well maintained. So being able to draw a clear circle kind of around that whole thing just gives you an idea of that overall, we talk about the biologic activity of each of these tumors. This is one that's not overly aggressive. So just from looking at your options, that can lead you to that, even if you don't know anything else about your differential.
Nice. All right, guys. Any other questions? I saw Joe's answering some good ones in the chat.
Yeah, I mean, I also can't overstress the importance of those slides you were showing with the depiction of the location of the tumor in age. I had that on my phone when I was doing my tumor rotations, and I would pull it up very frequently. And that gives you just a general idea of differential. And especially when you're starting out, I think that's a great reference to have. Yeah, I had that exact picture on my phone saved, and I would reference that all the time.
It's a great jumping point. I know when I was a PGY too, I had no idea about tumor. Like, I was lucky if I was coming up with the name of a bone tumor, let alone a soft tissue tumor. So having this kind of a cheat sheet, if somebody asks you a question, again, it gives you kind of a shot of the differential. And again, I can't beat it up enough, but the take home just, again, is this bad? Not bad, scary, not scary. That's really, I think, the biggest take home from all of this is just identifying those features. And that's, you're miles ahead of everyone if you have that.
I see Carolyn's taking a picture for her reference.
He's just trying to get ahead of tumor rotation for this year.
Yeah, she's got to be ready to go.
Yeah.
All right, guys. I'll be sending out this video to everyone. If you have friends or colleagues that are not on our mailing list yet, please email me. I'll put my email in the chat and have them email me just so I can add them. We'll also be sending the PDFs out as well so that you guys can read through it too for your reference. So, all right, thanks for coming.
And then, as always, add us on Instagram, NJMS.orthopaedics, for some additional posts and just a little reference into our daily lives and things that we see in our residency program.
Yeah, we're trying to post some interactive content for you guys, highlight some good papers, do a couple case presentations through there. So we'd love to have you come engage with us. That'd be great. Jeremy, you want to stop recording at this point? That way we can make it short. So we don't have to do all the editing like last time.